Good evening everyone, this is Dr. Krishna Chaitanya. So today we will discuss about the part 2 which we mentioned previously, like approach to pediatric cardiac emergencies. So this is the part 2 session which we are going to discuss, because previously we had discussed in part 1 about rhythms, congenital heart diseases and all. So in this session we are going to discuss topics like cyanotic spells and post-transplant emergencies, and we will discuss about like bridge therapies of like Ecmo, LVAD, and pulmonary hypertension, and infective endocarditis or myocarditis, then Kawasaki disease, how it presents in emergency situations, and acute chest pain in pediatrics, and what are the like syncope, how they present and all. So we will try to cover these topics in this session. So initially we come to cyanotic spell. A hypercyanotic spell, yes, cyanotic spell is where child turns into completely bluish in color and becomes desaturated eventually by due to, and this all cycle happens because primarily because in a cyanotic spell, what is the main pathophysiology is there is completely shutdown of pulmonary blood flow, because severe reduction in pulmonary blood flow that will last from several minutes to hours with a multitude of consequences. Yet what all can happen? Definitely even death can happen, like if the cyanotic spell doesn't revert back and there is complete severe spasm or complete obstruction of the pulmonary blood flow, child may go into complete hypoxia or severe metabolic acidosis, goes less than 6.1 pH, and eventually death may ensue. So usually sometimes if it lasts, if it is a cycle actually, cyanotic, whenever cyanotic spell happens, the cycle keeps on going. At some point we have to break that cycle. Sometimes naturally, spontaneously, it may even regress. So the common physiological one which lands up the cyanotic spell component is usually a large unrestricted ventricular septal defect, which results in equalization of the pressures in both the ventricles. Yes, exactly. So what is the most common pathophysiology found in most of the congenital heart defects which present as cyanotic spell is a large VSD. So what happens because of the large VSD? There will be like bidirectional flow usually. So, but when the pressures, because of the bidirectional flow, the pressures in the both ventricles becomes equal. So once your right ventricle pressure reaches almost like of the left ventricle pressure, and because of that severe pulmonary hypertension may ensue, the and because of that severe pulmonary hypertension or complete obstruction of that flow, and pressure developing in the right ventricle, blood may flow in the unidirectional from right to left, and that's where your complete desaturated blood goes through the VSD into the left side of the circulation, and child becomes completely severely cyanotic and all metabolic acidosis ensures, and there is completely absence of pulmonary blood flow because nothing is going through RVOT, and because of that there is no oxygenation process. Yeah, we see hyperpnea. Hyperpnea is defined as rapid and deep breathing, which is the hallmark of hypercyanotic spells. Yes. So during a cyanotic spell, the ejection systolic murmur decreases in intensity. Yeah, this is what we were discussing, because the main pathophysiology of cyanotic spell is completely absence of the pulmonary blood flow. So usually the ejection systolic murmur which occurs in the VSD is not due to the flow through the VSD, but it is due to the flow which is being going through that RVOT tract. So once that blood flow through the RVOT stops, there won't be any ejection systolic murmur. So sometimes you may feel that completely absent murmur, only S1, S2 is heard. So before a child who is having murmur and now presenting in cyanotic spell, usually the murmur may not be appreciable. So cyanotic spells usually self-limiting, last about some 15 minutes to 30 minutes, and when the infants may be lethargic or somnolent, and most of them, because sometimes they may become unconscious, sometimes they may become unresponsive. So prolonged hypercyanotic spells that are not treated can lead to hypoxic neurological injuries, seizures, cerebrovascular accidents, and deaths. So like what we discussed, lungs usually because the completely desaturated blood through the left ventricle goes to the brain, and the brain may get hypoxia, hypoxic injury. Child, this cyanotic spell may turn into seizure, and from the seizure the child may go into consequences like death. So what are the three initial managements you have to take up? The inpatient always first thing, position, keep him in the knee chest position. So even if it is an infant, just make him knee chest position to sit or hold them in the knee chest position in the mother's lap. So just flex the lower legs and onto the abdomen and flex the upper limbs and all. Make him to chest. So what happens with this knee chest position? Nothing. Just you are increasing the afterload. So you are trying to increase the left ventricular afterload so that you have to increase the left ventricular pressure, because of which your right to left shunting decreases. Because once your left ventricular pressure develops more because of that increase in afterload, your shunting from the right to left decreases and again shunts back left to right, and that cyanotic spell gets broken. And that's it. That is the normal physiology which the child accustoms naturally, even without training most of the time. So some 10 years kid or 8 years kid, he himself knows while he is running, suddenly he develops dyspnea and he just squats. He sits himself into that knee chest position. Nobody trains him. He learns it out of his own natural physiological drive. That's the nature's thing, how he has to make up life. So the most common initial first remedy for the treatment in cyanotic spell is always knee chest position. Then oxygen, always oxygen, because he is completely getting desaturated. Complete left side circulation in the throughout the body is getting desaturated blood. So give 100% oxygen always. Then intravenous fluid boluses, because he is completely getting dehydrated. Because, most of the time this hypercyanotic spell gets triggered because of his any acute situations. So always give fluid boluses. Then what all you can give? Intramuscular or subcutaneous morphine. Then phenylephrine infusion, 5 mg per kg per minute. If not decreasing, go for esmolol infusions, 100 mg per kg per minute. Even if not responding, ventilate child, get intubate and ventilate, because you can't take the risk of injury to the life. Then go for urgent emergency BT shunt placement, surgical intervention. Then differential diagnosis of congenital heart diseases, so based on the cyanosis, like what we discussed. So cyanotic patients with increased pulmonary blood flow or acyanotic patients with increased pulmonary blood flow. So what are the cyanotic conditions which have increasing pulmonary blood flow? So there is increased pulmonary blood flow, but there is mixing. Hence there is cyanosis. So it is truncus arteriosus, total anomalous pulmonary venous return, and transposition of great arteries. So these are the major anomalies where there is mixing and associated with pulmonary increased vascularity. So all these three conditions will have pulmonary hypertension. And what are the acyanotic patients with increased pulmonary blood flow? Yeah, they are VSD, ASD, PDA. These are the three shunts. Usually they are not cyanosis to cynos from day to day, but they can launch cyanotic spells in particular whenever there is right to left shunting. Then cyanotic patients with decreased pulmonary blood flow. Yeah, even these patients with decreased pulmonary blood flow also can launch a cyanotic spell, because decreased pulmonary blood flow, even a common illness, viral illness or some dehydration may land up these children into cyanotic spells. And particularly tetralogy of Fallot, tricuspid anomaly, tricuspid atresia, Epstein's anomaly. And what are the acyanotic patients with normal? These are like completely other than out of the heart, maybe, or some left side lesions, coaction of aorta, aortic stenosis, or even pulmonary stenosis. Then we deal with the other type of emergencies. So we are done with cyanotic spell and basic line management, how we do. So we are basic thing I want to tell, we are not dealing with each and every emergency in detail. The main purpose of this presentation is to give a broad spectrum of what are the various diffuse modalities of emergencies which can be presented, and what is the line of treatment what we follow. So we will be very brief regarding it. So post-transplant emergencies. First most common, acute rejection. So how do you treat it? How do you know that acute rejection? Very simple. You get to know that the heart is failing, decreased ejection fraction, and ECG changes, ST elevations and all. And also you get high cardiac enzyme, NT-proBNP markers very high, and inflammatory markers going very high. Child then treatment is with acute rejection treatment. Always you have to go with steroids or antithymocyte gamma globulins, ADGAM, which one? And next most common infection post-transplantation is always, because they are immunosuppressed, they are so high risk of infections. So usually they have to be treated with broad spectrum antibiotics. Then comes our next part where we deal mechanical circulatory support. So what is mechanical circulatory support? So mechanical circulatory support is when, like how you do for respiratory support, mechanical ventilation. So when somebody child unable to breathe, having some issue with oxygenation, lungs are bad, pneumonia or ARDS, the way how you are supporting with mechanical ventilation. The same way, when your heart is weak, some myocarditis or Kawasaki, severe Kawasaki shock, or a child's heart, some congenital heart cardiac disease, post-operative, heart is unable to come out of that injury, myocardium, vulnerable myocardium, failing heart. So that's where, or some cardiomyopathy, congenital. So that's where you have to go for mechanically even supporting that heart. So usually they are used as a bridge to heart transplant, or a bridge to recovery, or a bridge to take some decision what to go in the future. Because if you are not going to bridge, the cardiac activity is going to arrest, the child is going to die. So you have to bridge it to take up some decision, or give time that heart to recovery, or get a transplant or something. So in general, like they are long-term support systems or short-term support systems. So in short-term support system, the most common one is Ecmo. So extracorporeal membrane oxygenator with pump system. So short-term mechanical support with Ecmo is used in acute treatment, cardiogenic shock, or ventricular dysfunction after cardiac surgery, so that with expectation the patient will be recovered over a period of time, maybe 48 hours or 72 hours, or maybe even 4 or 5 days it may run. So it usually acts as a bridge, so that whatever post-operative heart or some viral infection, cardiogenic shock, myocarditis, it may recover. During that time, your ECMO support will maintain your complete systemic circulation and vital organ perfusion. So how the Ecmo circuit works out, and this is the Ecmo machine, how it appears like. So this is a machine where you get readings, and this is the knob which rotations per minute which you can adjust. So you can display of the flow liters per minute will be displayed here, and the below column machine is like a temperature thermostat, like which maintains the temperature. We can set the temperature where you get like temperature humidifier in the mechanical ventilator. This acts as the same. It acts as a temperature regulator for the ECMO circuit, and you can see there is an inflow system, there is an outflow system, and this is a oxygenator device. This is a pump, circulatory pump, and oxygenator device. So it functions on the centrifugal force, where so the pump will be making its rotation on the complete centrifugal force, where the inflow pump is completely extracted, gone made rotated through that, and through that membrane oxygenator blood flows. So it provides 100% oxygen. You can titrate the FiO2. You can ranging from 40-60, you can titrate the FiO2 whatever oxygenation you can give, and the oxygenated blood goes through that centrifugal force pump, and it pumps the blood again back into the external kit. So this is the original device, and this is the flow diagram, where this is a membrane oxygenator. From then it goes to directly into the aorta, and this is the cannula in the superior vena cava and right atrium. From here it is going into that pump, where that pump works on the centrifugal force, and this pump so pump bloods into the membrane oxygenator. So like circuit keeps on growing. Then so this ECMO device is usually a short-term mechanical support, whereas long-term mechanical supports what we have as VAD, so ventricular assist devices. So VADs are typically employed for long-term supports where cardiac dysfunction, and where you are anticipating a cardiac transplant maybe next month. Registry donor has yet to come, or some cadaveric transplant you want to make, or some brain dead somebody. Cadaveric means some brain dead, not cadaver. Maybe somebody is brain dead and his working heart is extracted, and that is being transported through green corridor system, and then transplanted if you are expecting. Then that way you some time may take. So you have to bridge this child, or else he may die within hours. So if you want to bridge that child for at least few months or few days, you have to go for ventricular assist devices. So prompt defibrillation, cardiopulmonary resuscitation, and anti-arrhythmic therapy, if the ventricular attack is refractory, should be always employed, because these though assisted devices they can anytime fail. So this all needs to be taken care of at every moment. Then in addition, extracorporeal membrane oxygenation resuscitator during resuscitation, which is called as eCPR. ECMO during CPR should be mobilized if available. So this is the most interesting topic, which is known as eCPR. So CPR everybody know through the pulse, like if somebody cardiac arrest happens, you go for CEAB. So what is eCPR? So whenever you are working in an institute where you have cardiac cardiologist backup, cardiac thoracic surgeon backup, and ECMO circuit unit complete backup. So somebody cardiac arrest is going on, you immediately call for the response of the cardiac team and you start ECPR, where you immediately take the child for starting up the Ecmo, because cardiac arrest, the myocardium is going to be vulnerable for at least for next 48 to 72 hours. So you have to give time to recover it. So we immediately try to get cannulization, central cannulations usually, and connect the child to. So American Heart Association Pediatric Advanced Life Support Guidelines for in-hospital cardiac arrest recommends always consideration of the ECPR in children, especially with if heart diseases and if the conditions are likely to be reversible or amenable to heart transplant. So overall, survival to discharge in pediatric ECMO patients is 50% and 41% for ECPR. That's very good numbers actually to say. So this survival varies with age, indication, and even cardiac diagnosis. So children with myocarditis have the highest survival to discharge of any cardiac ECMO diagnosis, especially with a rate of up to 72%. Just imagine if there is no ECMO bridging or there is no ECPR, you are going to just do a CPR. Your child may revive back or may not revive back. And in hospital cardiac arrest, revival chances are only 20 to 25%, and hardly it may go up to 40%. But in myocarditis, if you have ECMO unit backup and if you do ECPR, your survival rates may come up in even 70%. Then LVAD, left ventricular assist device. So left ventricular assist device is a pump connecting the left ventricle to the aorta. You can see the picture in the diagram. So where you will have a pump device, and it may be pulsatile or non-pulsatile. There are again two types of the devices. So one cannula will be in the aorta and one cannula will be in the left ventricle. So they could be used as a bridge to transplant where there is not much of hope for recovery, and the bridge to recovery cardiac function is likely to recover or a suitable candidate for the heart, like what we discussed before. So they are being, and one more thing, ventricular assist devices are also being used as destination therapies where there is no plan to bridge to transplant. So suppose somebody, there is no available transplant or they may not be affording to transplant or whatever the reasons, but if they are only making up to left ventricular assist device, there are trials going on just to use it as a destination therapy even. So based on the types of the flow, yeah, they can be pulsatile or continuous. So these are all devices predominantly being devised for the adults. But for the children, only one FDA approved device is there, Berlin Heart Expert device. Yes, definitely there are trials going on to bring up more ventricular assist device and all. So IABP, intra-aortic balloon pump, and total artificial hearts are also more used in adults. We are not familiar to use much of IABP in pediatrics, but yes, Berlin Heart Expert is. So here are the pictorial representations. So LVAD is left ventricular assist device, and RVAD is right ventricular assist device, where your cannulas will be in the pulmonary aorta and the right ventricle, and BIVAD is biventricular assist device, where you have the both pumps, and total artificial heart, where you have the complete total artificial heart you use in situations where the complete because of the cardiac is completely damaged or severe dilated cardiomyopathy, where it is ejection fractions less than 10% and no transplant options available and long-term patients need. So you will use both the pumps and just connect them to the one in the pulmonary artery and one in the aorta, and you even venous connections you take. So this works as a total artificial heart, and these are the first generation, and second generation is heart made, third generation is like you have, but these are all trials are going on in the adults. So you can see pictures like they will have a bag, the patient, he will be even walking. If you take a chest x-ray, you will see the device, and if you check for the pulse, there will be no pulse. It is a non-pulsatile, so it will be running through that centrifugal force. So IABP and total artificial, but these are all predominantly more in adults. In pediatric, it is only Berlin Heart Expert. So that's, we are done with that. Then next our emergency presentations are pulmonary hypertension. So how pulmonary hypertension presents as an emergency? It is though an uncommon but potentially life-threatening condition, and it has definitely mortality rate. And if we are able to deal with it, identify early and intervene timely, definitely survival chances are also very good. And usually a loud pulmonic component of the second heart sound is an important diagnostic clue in the presence of the pulmonary hypertension, because as high diastolic pulmonary pressure will force the pulmonary valve to shut against great intensity. Yes, just like systemic arterial hypertension, where you have very high pressures and aorta and left ventricle has to pump against that high pressures. The same way, when your pulmonary pressures are very high, maybe due to reactive, primary or secondary, you will have a loud P2 component. Then emergency intervention. So what you can do for pulmonary hypertension? Once you diagnose pulmonary hypertension, first always Keep the child calm, keep the child quiet, let him not cry, let him be comfortable, don't touch him much, don't try to poke with IV needles and all, no much handling, give only 100% oxygen, if possible sedate the child and suction the airways, because even a minute amount of airway blockade or some minimal hypoxia triggers pulmonary hypertension like anything. So always remove the mucus plugging and keep nasal suction frequently. If possible, ventilate the child, completely sedate and paralyze the child. Take complete breathing into your control. Get the pulmonary hypertension settled over next hours or next days of life. So, and hyperventilation, yes, definitely hyperventilation, washing out of the CO2, definitely even breaks down that pulmonary hypertensive crisis situation, because as we know, oxygen is a potential vasodilator in pulmonary circulation. So the more potential vasodilator. So the more you give that pulmonary hypertension, that hypertension, whatever that pulmonary pressure which is under tight spasm, it relaxes usually. Whereas systemic, it is a vasoconstrictor, but in pulmonary it is a vasodilator. So the addition of inhaled nitric oxide, yeah, even nitric oxide is even more potent vasodilator than oxygen at the doses. But yeah, straight away go to 20 ppm. There is nothing to start at 5 ppm, 10 ppm, either something like Ayurvedic or homeopathic dosage what you use. If you want to start nitric oxide for pulmonary hypertension, straight away go for 20 ppm, and it produces effective pulmonary vasodilation. Once if you achieve a stage where you control that pulmonary hypertension, then you can slowly come down on tapering the nitric oxide ppm, and usually it will be after some 12 hours at least. So, but if you couldn't find the response, if your PO2s didn't improve, or if your CVP didn't come down, or your pulmonary hypertension is still high, you can, if you can measure pressures or through echocardiography or invasive things, but if it's still high and not responding to nitric oxide even after some 2 to 3 hours, there is no point in continuing that nitric oxide therapy. Then you have to go for another alternatives. So then we come with the another next model. So other than inhaled nitric oxide, there are even trials which we are going to use, especially in neonates and infants, sildenafil infusions and milrinone, magnesium sulfate. So multiple other drug infusions are being tried as pulmonary vasodilators. Then young children with left heart obstruction usually present with respiratory or GI symptoms limiting pneumonia, bronchiolitis, even asthma like cardiac wheeze, they can present. Then another emergency situation like chronic thromboembolic pulmonary hypertension. It is a specific subclass of pulmonary hypertension that represents the cumulative effect of acute pulmonary emboli that have not completely resolved. So suppose somebody child may have some hypercoagulability disease and they land up in pulmonary embolization, and because of that pulmonary embolization your backward pulmonary hypertension develops, and they may develop into thromboembolic pulmonary hypertension phenomenon. So for this, always a pre-existing hypercoagulable state is most commonly diagnosed. So risk factors for CDPH are like what we said: hypercoagulable state, it can be due to thrombophilia or some malignancy or even some sepsis or even pregnancy like in adults and all. So this is a virtuous triad, what we say, like stasis of the flow, endothelial injury, hypercoagulation like thrombus, like what we read in pathology. Then Cdph is one of the few subclasses of pulmonary artery hypertension which is potentially curable. Yes. So patients diagnosed with CTEP should be rapidly transferred to the cardiac center, and surgical pulmonary thromboendarterectomy or catheter-based removal or lysis of the thrombotic material may be used. Yes, definitely. These are cases cannot be managed in normal pediatric centers. They need to be referred to the cardiac centers where they may need emergency surgical or procedure, cath lab procedure to remove thrombectomy procedures. They may be underway. In acute settings, especially when patients' candidates PT is being given, heparin is the anticoagulation of the soils. Obviously, they have to be started on heparin infusions so that the thrombus or emboli don't get increase more and cause complete obstruction. And heparin can be titrated based on the individual's anticoagulation protocols. Like we target range of APTT or PTTK or range up to 60 to 80. Yeah, normal will be up to 30, but in case whenever you are on heparin infusion, you target your 60 to 80, and targeting your 60 to 80 APTT, you either increase the dose or decrease the dose with 10% whenever you repeat that. Then next comes is vaso-occlusive pains, the emergency what they present. Sickle cell disease children, they present to emergency with acute chest pain, vaso-occlusive disease. So they may need opiate analgesics even for relief, and hyperhydration. Start like bolus, 20 ml per kg bolus. You hyperhydrate. Then we discuss emergency interventions. So what are the emergency interventions which can be needed? So BAS, balloon atrial septostomy. So when do you need balloon atrial septostomy? Usually in cases with DTGA, where the intact septums are there and there is TGA. So your pulmonary artery is arising from the left ventricle and your aorta is arising from the right ventricle. And suppose if both atrial septum and ventricular septum are intact, so it is impossible to live postnatally. So definitely the child will collapse within hours. So that child may be taken for balloon atrial septostomy before you go for corrective surgery, because the moment you make balloon atrial septostomy, the left and the right something mixing will happen so that the blood flow goes in series circulation. Or else what happens, if there is intact septum and there is DTGA, two circulations will be completely parallel and there will be no mixing. So there will be no point, no oxygenation, nothing. So you have, if you try to make a balloon atrial septostomy, there will be, you will allow some part of mixing. So there will be a series connection. Then pericardiocentesis, acute pericardial effusion, pericardial tamponade. So you have to go for pericardiocentesis, immediate decompression, or else the child may go for cardiac arrest. Then balloon valvuloplasty. Yes, this is also an emergency intervention where you go for severe pulmonary stenosis, severe aortic stenosis. The child presents in completely cyanotic spell or completely severe circulatory failure shock. So you have to go for emergency balloon valvuloplasty. Then another emergency procedure which is upcoming in cardiac centers, most recently advanced, RVOT stenting. So yeah, definitely, and ideally procedurally placed, timely placed RVOT stenting even can prevent a open heart surgery. Especially in cases of like tetralogy of Fallot. Nowadays, people are trying to go for RVOT stenting in order to avoid complete open heart surgeries. So RVOT stenting is a stenting device where you deploy a stent in your RVOT and it tries to keep it open. So there is always a flow from the right ventricle to pulmonary artery. Then transvenous spacing, emergency device, whenever you need this. Suppose a child comes with complete heart block. So you have to go for emergency transvenous spacing, like you have to put a central line and put a catheter where that goes up to the superior vena cava or junction with right atrium, where you will implant an electrode. So that's where transvenous spacing, and you will connect that wire outside to the external pacer box. So this may happen where you will get complete heart block, Lyme disease, lupus disease, diphtheria. These presents with a complete heart block. So that child may need emergency transvenous spacings always. Then recannulating blocked shunts. This may emergency. Suppose the child maybe had performed BT shunt some 3 months back. Now the child comes with completely again repeated cyanotic spells and all, and child is in complete circulatory shock like stage. So if you hear there is no flow, you could see. If you show echocardiography, the shunt is completely blocked. So the child needs emergency recannulating that blocked shunt, or else because child may die. So these are the emergency interventions which may be needed. Then avoid beta agonist in bronchiolitis in congenital heart diseases, because yeah, we discussed this last time also in part 1. Tachycardia causes increased myocardial consumption and worsens cardiac function, and preferably use high flow nasal oxygen or racemic epinephrine. Then causes of the cardiogenic shock, yeah, we discussed it in the last episode also. Like day 1 of like, usually it is birth asphyxia or TAPVC or TGI with intact septum, or HLHS, hypoplastic left heart syndrome, and those with presence in the first week of life are duct dependent systemic circulations or duct dependent pulmonary circulation lesions, and next after weeks are like VSD, ASD, and older children it may be due to arrhythmias or Kawasaki diseases, cardiomyopathies and all. Then another most common emergency which may be presenting is infective endocarditis. So life-threatening infective endocarditis may see suddenly child may present heart failure, severe systemic manifestations, and rash over the body and conjunctivitis, or even sepsis present, high inflammatory markers. If you see, there are severe vegetations completely sitting on the walls, obstructing the blood flows. So patients with acute rheumatic fever or mild to moderate cardiac disease should be treated with high dose aspirin completely. It's not like something 3 to 5 mg antiplatelet dose. It is actually anti-inflammatory dose, which you go for even 80 to 100 mg per kg per day, which you divide it over 6 hours in children. And presents with severe valvular insufficiency or hemodynamic compromise should be evaluated for urgent surgical interventions. Definitely, if there is a big, large chunk infective endocarditis mass or some sitting on that valve and making severe valvular insufficiency, and your LV keeps on distending, it will go into cardiac arrest. You have to make the child to urgent intervention to do something. Then Kawasaki disease is another emergency which may present with hemodynamic compromise. Kawasaki shock, which is called as Kd shock. So the child may be needing inotropic infusions, vasoactive infusions. So treatment is always try to start aspirin immediately and treat with IVIG, 2 gram per kg per day. 2 gram per kg completely given over 48 hours. Then, initial treatment of myocarditis is aimed at supporting cardiac output, and pediatric heart failure guidelines suggest usually milrinone, preferably always milrinone or dobutamine as first line agent in for children with decompensated heart failure. Okay, this is most point you see. Whereas epinephrine is reserved for patients with refractory hypotension and poor end organ perfusion. So whenever somebody child who is landing up in heart failure but able to maintain good tissue perfusion with good blood pressure, then always your drug of choice will be milrinone or dobutamine. Whereas if child is already decompensated and is having hypotension and having end organ perfusion impairment, then you can't go for using your milrinone or dobutamine. Then you have to always go up with your epinephrine. Then digoxin is usually not recommended in this phase because it has increased myocardial injury cases. Then your next coming emergency which can be presenting is dilated cardiomyopathy. In an acute clinical scenario, usually in pediatrics, don't just think of only congenital dilated cardiomyopathy. It can be even acquired also, maybe due to vitamin D deficiency or calcium deficiency. So try to treatable causes we should always be trying to rule out. And persistent tachycardia in the absence of usual cause and cardiomegaly on chest X-ray are pointers of cardiac possible cardiac dysfunction. So like if you see an X-ray, there is cardiomegaly and there is persistent tachycardia or tachycardia in the absence of any known cause. So you have no cause, you don't know the reason, but there is tachycardia, and if you take an X-ray, there is cardiomegaly. Definitely you think of there is some cardiac dysfunction. Then the next emergency we are dealing with stroke. Definitely cardiogenic stroke. Here we are not going to discuss about a neurogenic stroke and all. Our target is cardiogenic stroke. Yes, pediatrics especially stroke, and especially here we are not discussing about stroke due to any hematological problem or anything. Here we deal with stroke due to cardiological problem. So some congenital heart disease presenting with stroke. How it happens? Always cardiac heart disease, stroke, there is always right to left shunt, because it is unlikely to happen for a stroke or thromboembolic event with left to right shunts. Stroke has to happen in congenital heart diseases, usually cyanotic or acyanotic, whenever there is some right to left shunting. So from some vegetation or some thrombi from the right side, which gets bypassed of the pulmonary circulation, where the filtering doesn't happen, and straight away it goes through the left side into the aorta, lands up in some brain or pulmonary artery or some coronaries or wherever it sits, and it causes thromboembolic phenomenon. So always in unrepaired diseases, endure normothermia, endure normoglycemia, treat if any seizures, and maintain cerebral perfusion. Then go for CT or MRI imaging. If you see any brain abscess, yes, definitely some septic foci, co-vegetations, send a culture first, because it may be infective endocarditis causing brain abscess. Start with a broad spectrum antibiotics. Then if it is an arterial infarct, start up straight away on heparin infusions. Use anticoagulation infusions for 3 months. If not, for infusion you may run for 2 to 3 days and later convert it into oral. Usually warfarin oral you give and you send back them home. And thrombolysis, we are not doing thrombolysis in pediatrics. Yeah, this using of recombinant things, thrombolytic enzymes, we are not using in still pediatrics. It's not recommended yet. Maybe in near future we may come up with the pediatric recommendations also. Then cerebral venous infarcts, yes, hydration more, and phlebotomy if your HB or hematocrit is more than that, because always high hematocrit is also a reason for causing stroke. So if it is very high, definitely you make for phlebotomy and letting out the blood, so that targeting your hematocrit at a normal range. Then and next infections which are all possible, which can present as emergency with cardiac thing, is tetanus. How tetanus is going to cause cardiac emergency? With the dysautonomia, sudden hypertension, sudden hypotension, child vitals hemodynamically completely unstable, and with some rhesus sardonicus or tetanic spasms or some Quastec signs child may be developing. What you do? Tetanus antitoxin. How much? 500 international units. And what all you can do for dysautonomia? If there is severe hypertensive crisis and all, go for labetalol infusions, or you can use magnesium sulfate, or you can use clonidine. Then what other infection causes can present with cardiac emergency? Diphtheria usually. How it causes? It causes complete heart block. It causes myocarditis. Diphtheric myocarditis really is potentially life-threatening. It is very lethal. It's completely. We have seen completely dilated hearts with ejection fraction less than 10% who are going to succumb to death within hours, and they are completely acutely bradycardic, complete heart block. So these children have to be sent for transvenous pacings. So immediately you have to give antidiphtheria syrup. How much? 50,000 international units. If not available, what you do? Go for IVIG. Then cardiac wise, what you can do? Start upon digoxin or give furosemide. Start carvedilol infusions. This carvedilol, though it is not going to act on the day one, but it acts for the future. Then we deal with chest pain. So contrary to the belief at a large in the community, etiology of the chest pain in pediatric patients is mostly non-cardiac. As usual, even in cardiac it is adults also it is non-cardiac, and even in pediatrics it is non-cardiac. So whoever complaining of the chest pain, it is not always cardiac. It may be due to pretty respiratory, pneumonia, or even some gastritis or asthma, cough. They may just complain of chest pain. And one more thing, most common cause of the syncope is vasovagal syncope. A sudden somebody telling we are falling down. Just don't confuse between syncopes and seizures. So syncope is just loss of consciousness, and usually it is most commonly due to vasovagal syncopes, and it most commonly is the reason for 40 to 50% of the cases presents into pediatric emergency department with syncopes. And patients with vasovagal syncope typically have normal cardiac examination. No murmur is heard. You do ECG, you do X-ray, you do echo, everything is normal. And any abnormal finding should prompt for underlying the diagnosis and all you should see. So what happens? If there is any underlying systolic ejection murmur, always think of some hypertrophic cardiomyopathy or aortic stenosis. If there is some gallop rhythm, think of some myocarditis. If the rhythm is irregular, just get a 12-lead ECG, check whatever the rhythm. If you could able to hear some pericardial rubs or some high JVP, think of some pericarditis or cardiac tamponade or myocarditis, what is going on. Then ECG may be valuable in identifying these all things. Yes, definitely, as we discussed. So if your ECG is showing some left ventricular hypertrophy or united T waves, definitely it is some hypertrophic cardiomyopathy you can think of. Especially when these all are for ECG when there is syncope. So how you suspect myocarditis in child with syncope? Yeah, sinus tachycardia, T-wave inversions, long QRS voltages in the limb leads. Especially the most characteristic feature is this T-wave inversion. Always remember, syncope child, T-wave inversion, think of myocarditis. Then pericarditis, definitely generalized ST elevations. So like ischemia, how you see ischemia in adults, ST elevations, that way pericarditis is going to present with tachycardia, with syncope in your children. So these ECG are characteristic findings and very diagnostic. So then Alcapa, anomalous coronary artery origin from deep from pulmonary artery. So how it presents with your ECG, deep and wide Q waves in the lead 1 and AVL, and T wave inversions and ST elevations in precordial leads. So this is also characteristic ECG appearance. You see Q waves in lead 1 and AVL, and T wave inversions in inferior lateral leads, and ST elevation in precordial leads. So these three are characteristic features of Alcapa. Alcapa is again like myocardial ischemia, because you see when your coronary artery is arising from the pulmonary artery, which is completely desaturated blood, ultimately it is going to cause myocardial ischemia. Then arrhythmias. So arrhythmias presenting usually in pediatrics are like with cardiac emergencies, like we discussed previous last time only, like narrow complex tachycardia, wide complex tachycardia, long QT, SVT, Brugada, and fibrillations and all. We in the part 1 we discussed in clear. And upcoming topic we will be more discussing in clear about approach to wide complex tachycardia in pediatrics. We will deal in detail about in our next session. Then pulmonary embolism, as we already discussed, even ECG you can get like RV strain pattern. Then like final we'll just make up the child with approach to evaluation in a pediatric child with a murmur. So appearance of the child. So whenever it's not like just you hear the murmur, it's not my part, I am sending the child to the cardiologist. No, don't think like that. As a pediatrician or as a practicing pediatrician or even postgraduate or even whatever, so you should know the approach. So it's not just a murmur you auscultate and you think you have done something. You have to just classify the child into whatever you like to know. So appearance, just look at the appearance of the child. The child is well appearing, then what you see, if it is a systolic murmur, then likely it is a still murmur, because even anemia or some flow murmur also can be there. So just cardiology consult if the nature of the murmur changes or persists, or else you need not send him to cardiologist. Then if it is well appearing child, but the murmur is very definitely short systolic and radiating to axilla and radiating to back, then definitely think of some peripheral pulmonary stenosis. and consult cardiologist if this is persisting beyond 1 year of life. Then, if the child is ill appearing, sick looking, failure to thrive, completely sweating, mother complaints of intermittent child turning into blue in color or whatever, then definitely he is a ill looking child. Then you classify the murmur. It is a holosystolic or diastolic murmur. You have to differentiate. How you differentiate? Check the murmur along with central pulse or peripheral pulse and see whether your murmur is arising along with the systole or along with the diastole. Then, if it is a holosystolic or diastolic as continuous murmur, think of VSD or PDA. Then urgent cardiologist consultation you take, get a 2D echo and send to cardiologist. If it is a new onset holosystolic or diastolic murmur associated with fever, take cardiologist opinion, get a echogram to rule out infective endocarditis. Why? Here fever is there. Okay. Whenever you are hearing a new onset in a completely normal child, but now presenting with murmur associated with fever, yes, think of infective endocarditis. Okay. So this is the reference what we take for the entire presentation. A practical approach to diagnosis and management of cardiac emergency in children by Ashok Sarnaik and Robert Steve Lufkitz, published through Springer. So guys, hope everyone understood the basic. In these two parts, we tried to discuss the what are all the various different types of the cardiac emergencies and how to deal with them in the just like basic level. What is the approach we do and how cardiac emergencies are different from non-cardiac pediatric emergencies. So hope everybody had understood and had a basic idea how to differentiate and how to follow like a algorithmic or wise. If you still have any doubts, do mail me back or message me back. So we will come up with next session with approach to wide complex tachycardia and we will deal it in the next. So thank you. See you soon.